All right. Well, good afternoon, everyone, to our February 5th meeting of our Thriving Together board. I'd like to welcome you. I'm coming to you from the traditional lands of the Confederated Indians of the Colville Reservation, and I am specifically on the ancestral lands of the Sampoil. So at my home here at Keller Ferry. So that's where I'm at. As we get started here, we'll start with a little Zoom etiquette. If you're able to keep your cameras on, that's great, so we can see you in the Hollywood squares. Also, don't be afraid to use your reaction features. If you've got a question, and unmute when you're ready. And if I've missed a Zoom etiquette, let me know. All right. With no further ado, let's go to roll call. I'm just going to read down the line and you just tell me if you're here or not. Del Anderson? Manuel Navarro?
I'm here.
Rosalinda Kibbe? We know Senator Warnick's not here. Teresa Atkinson?
I'm here.
As you say, I know you're there. Maddie Osborne?
I'm here. Good afternoon.
Good afternoon. Molly Morris?
Here.
Nancy Spurgeon? I thought I saw Nancy. Maybe not. Okay. Peter Morgan?
I'm here.
Ray Eichmeyer? Oh, Ray. Carlene Anders?
I'm here.
Myself, Linda McKay, and Lori Bergman.
I'm here.
All right. Well, again, welcome everybody on this. I don't know about where you guys are at this rainy Monday afternoon down here on the Sampoil Columbia River for me with a little bit of wind. Okay. As we get started, does anybody have given the agenda and the topics on the agenda, a declaration of conflict that they need to disclose? Okay. Wait time is my friend. Hearing none, we'll move on to, do we have any public comment? Hearing none, I'll ask if there's any questions around the approval of the consent agenda. You can find on the consent agenda our minutes on pages 3 through 4 from December, our monthly financial report on pages 7 through 9.
Linda, the only other thing I will call out just as a reminder, so as part of the consent agenda, we have 2 contracts for approval, one for Catholic Charities and one for North Central Washington Technical Alliance. Those are attached separately in the meeting request for all board members, just because we felt like with contracts, we don't want them out in the public agenda. And so they were reviewed and discussed at the Finance Committee and recommended to bring forward for the board in the consent agenda. If anyone has any questions about them, we can answer them, or if there's any other concerns, we can always pull it out of the consent agenda. But this was the process we used for the last one.
Thank you, John. Would anyone like to entertain a motion to approve the consent agenda as presented?
This is
I move
Carlene.
that we approve. Oh,
Go ahead, Peter.
I move that we approve the consent agenda as proposed.
And I'll second.
Okay. It has been moved and seconded to present the consent agenda as proposed. All those in favor say aye.
Aye.
Opposed? Hearing none, motion passed. Well, that was easy. Okay, John, Executive Director update.
All right, well, happy February, everyone. I think One thing I'm just going to share today is there's going to be a few updates in my executive director report. I'm also going to be asking staff throughout my report to share on some specific topics. So you're going to have some time today just to be able to hear a little bit about the work going on as we get into 2024. And then starting the next meeting, we're going to be, for the rest of the year, continuing to bring partners in to present to us. But before we really jump into the executive director report, I just wanted to allow Maddie an opportunity to share an announcement and in reality before she's even able to get on to speak. And this will probably be part, give it away. I really just wanted to thank Maddie for everything she's done for our board and the collaborative nature she's had. She's been an amazing MCO partner. And with that, is Maddie still on?
I'm here.
Looking for her. Oh, there you are. Sorry, I had
I'm here.
a
Hi, guys.
notice pop up. I'm going to turn it over to Maddie without sharing much more and let her speak.
Yeah. Hi, everybody. Good afternoon. And sorry to spring this on you, but as a result of a work organization, like a reorganization, they're doing a reduction in force. So they're largely eliminating my division here at my health plan. So that means that my last day here is on Friday, and I've known for a number of weeks. I'm exploring employment within the organization, but not really sure. So, but yeah, so it's just been, so that just does obviously then ripple effect. So as a result of that, I will need to step down from my position representing the managed care sector here with Thriving Together. I've been working with the ACHs since their inception. I live here in Pierce County and was able to help at the health department when they were getting the Pierce County ACH set up. So it's been it's been a history, and I've known a number of you and been so fortunate to work alongside you, to come on site, to work with you on a number of projects and programs and sponsor. And I'm really proud of all the work that Thriving Together has been able to accomplish. And I'm excited to continue watching you guys and rooting you on. I'm really trying to make sure that the commitment for WellPoint, so formally as of January 1, we were rebranded to WellPoint from AmeriGroup. And so I'm really trying to make sure that our commitment is steadfast in my absence, and I'm working with the other MCOs for coverage also, so there's not a gap here. So, but yeah, it's just been a really pleasure to work with you all. And John, I feel like we've become friends and colleagues, and you've helped me in my work starting this new division. And so that's been a real pleasure, and I don't see that going anywhere. So I'm on LinkedIn. I will put my personal email in the chat if that's okay with you all. Please feel free to reach out if you have questions, if I can support the organization, or if you have any questions about managed care. I'm happy to help any way I can. But anyways, yeah, that's the news I wanted to share.
Thank you, Maddie. I just want you to know Teresa Atkinson is already trying to recruit you via chat. And thank you too. Maddie's been an amazing board member, and she's been a very easy, collaborative individual to work with in partnership with the managed care organizations. And I feel like we're lucky to have her as our managed care representative on the board. So I was excited to have Maddie for 2 more years instead of the 1-year transition. And sadly, we're back to the 1-year transition. But I know she'll make sure all of this goes smoothly. If you want to bring back up the executive director report. Go to the next slide. So just a few things that at the state level, I want to keep you guys up to speed on. And in reality, when I think of, statewide conversations and accountable communities of health, it's really heavily focused on the Medicaid Waiver 2.0 renewal, and most of the conversations surrounding anything we do on the legislative side with healthcare authority, MCOs, and anyone else is really about how are we getting this waiver up and going, which I wish could be a little bit faster, but that's just not the nature of the process. So legislatively, the healthcare authority has funding approval in the legislature now for the remainder of the Medicaid waiver. So they had initial approval for year 1 for our infrastructure funds, and now they're really seeking approval for the remaining years out in the budget. Of course, as we go through each biennium throughout the 5 years, there'll also be stages where additional approvals need to be made just for the funding sources. There's no concerns that I am aware of at this point in time for that, so it sounds like funding will be approved. One of the things that was originally called out in the waiver that's tied to work with the accountable communities of health that they need additional legislative authority and they had to submit a legislative report on was the community information exchange work that the healthcare authority is looking at doing. My understanding from talking to legislators and our coalition lobbyist was that all seems like that is going along as planned, and that there is no concerns of that getting approved this year. Another resource directory CIE related topic that had come up this year that the ACHs were tracking, Washington State Win 211 had submitted a bill for what they were calling Whole Washington that really looks a little bit in the CIE resource directory space. My understanding in conversations is it did not make it past committees, and so it wasn't going to progress forward on, but this was going to look at in their sphere of work, how are we bringing state partners together and entities to look at more collaborative resource directory work. I would say the ACH just took a neutral stance on it. The really nice thing about it is this has just spurred additional conversations with this group, with other statewide partners. So even when the bills don't go through, sometimes it does push some of our statewide entities to have more discussions, which hopefully leads to more collaboration across the state and reduces how some of these efforts could be duplicated. And then again, I would go on the Medicaid waiver renewal side. Again, a lot of the discussion now is those original infrastructure and services protocols are submitted. And so how are we taking those into an operational level? I would say for the coalition of ACHs, one of the biggest pushes is really to get the healthcare authority to get this in contractual terms. So we know really what our requirements for this work is going to be over the next few years. The other thing that's really starting to come up a lot in discussions is there's a lot of focus around jail transition work in the waiver. And I'll share a little bit later, but a lot of that's slated to start July of 2025. And so Joey and I have been reconnecting with a lot of our local jail transition teams and groups to really learn how things are going on the ground as we talk with the healthcare authority and other statewide partners on what this work is going to look like under the waiver. If you go to the next slide. Just some regional updates, and I'm going to be calling on staff as I go through these slides to provide a little bit additional detail. Really in the realm of capacity building, we got feedback and information and surveys back around the art of hosting. And so I'm going to turn this over to Caroline to share a little bit about what they were able to summarize in that work. So Caroline, you are up.
Yes, so this is one of the trainings we sponsored last year. It was in response to some feedback we got through the partner survey that they were interested in more leadership development opportunities. So we did Dare to Lead, but we also brought in this training called Art of Hosting Meaningful Participation and Dialogue. And in your packet number 2, page 11, we shared a kind of one-page summary of that training, including some quotes and some pictures from the training. One of the things I wanted to share is that it's basically a 25-hour training, and we did 2 in-person days in Winthrop, followed by 3 online virtual sessions. And at the start of the training, we shared the vital conditions handout, the one-pager, and really called out the central condition of belonging and civic muscle. Because Art of Hosting really is designed to develop community capacity for action and community engagement around issues that are challenging cities and counties across the nation, really. And this is really a different way. It's a skill set that can be applied to any sector. And what was exciting is we had 44 participants there. You can see in the handout a majority of them were from Okanagan County, which isn't surprising because that's where we hosted it. But we had folks from natural resources and conservation districts and public health and tribal health and transportation. Like, we just had such a variety of partners there, including some that we had never worked with. And it was really exciting to see how everyone could see how they could bring some of these skill sets back to their own work. We got great feedback at the training and also in a post-training evaluation. So our recommendation is that we will bring it back again this fall. We hope to host it in Grant County this time so that we can hopefully really attract a lot of Grant County participants. And we will probably do one extra in-person day. That was feedback we got, is that it would have been nice to end on an in-person day. So this is just kind of previewing it for you, seeing if you have any questions, but just an example of the way we are investing in belonging and civic muscle across our region. So I will leave it at that and see if there's any questions.
I think Teresa's comment was that her staff really enjoyed the workshop.
Awesome.
Teresa, thank you for sending staff and supporting them in developing those skills.
Okay, John.
All right. Just a few highlights I want to call out in partnership with the Nonprofit Institute, which is the Community Foundation and the Icicle Fund. They just released, and if you get their emails, you'll see they just released applications for $5,000 grants that are designed for local nonprofits to collaborate directly with a consultant of their choice on a project to strengthen the organization's ability to fulfill its mission. So really what they're calling strategic partnership grants. We had done this last year with the Nonprofit Institute in partnership with them to help fund supporting these strategic partnership grants, and we had committed to multiple years of this work, and so they are just releasing their second round. We can find out, and I didn't think about this prior to now, we'll find out if we can get some of the information from the last grant cycle, if they have that summarized yet, so that we can share back some of the outcomes to the board. The other thing I wanted to call out in partnership with them as well is we are going to be doing grant writing workshops across North Central Washington over the next few months. I believe there's a 101, a 201, and a 301 that's spread out across the 4-county region. And my understanding, I had a chance to look at it the other day because I had an individual interested in the workshops. It looks like they are filling up fast, that a number of them are already full, and that there had been 1 or 2 additional offerings put on there. So it just kind of demonstrates that need as we're looking at building capacity around that strategic capacity and those strategic partnership grants, and then just helping nonprofits develop the skill of, or any organization that really needs that skill set of being able to write grants and seek grants to get additional funding into the region. And then the other thing I wanted to focus on around capacity building and network support is work Sarah has been doing with the Shared Measurement Task Force in getting ready and ramping up a rollout of a well-being survey to collect information around well-being and thriving. And I am actually going to turn it over to Sarah to share a little bit about that.
Yeah, and Caroline, do you mind putting up the packet? So I'm coming to you all a little bit early because I have a date with a new baby here this week. If not before Thursday, her eviction notice comes then. So I'm coming to you a little bit early so that if there are any questions, that I can help answer those before I leave. So we will be conducting a well-being survey starting mid-April and going through at least mid-June, possibly through the end of June. So we have a little kind of rollout packet that will be finished very soon, but for right now, well, why measure well-being? So it really is a critical indicator of community health, and is included in a lot of different organizations planning. So the Institute for Healthcare Improvement, Healthy People 2030, and across the country. And so it's something that we really feel like is important to have for our region and to be able to monitor our region's well-being. So this is the first of hopefully many well-being surveys. And we'll be using specifically Kentrell's ladder to measure that. So I am coming to you all because this really is a partnership with the Shared Measurement Task Force and our partners. And so we'll be asking all of you to help us spread the word about the well-being survey and to inquire with your organizations if it's possible to roll this survey out within your organization. So either with staff or with clients, perhaps putting a QR code up in your waiting rooms or lobbies, sending out through newsletters, emails, that type of thing. We will be providing a packet of example emails and social media and things that you can use that will be available on our website shortly. And it'll be available via SurveyMonkey and also via paper. So if you do a paper version, you'll just need to make sure it gets back to our office, and Mariah Kelly will be our go-to person, all things related to the survey, so she can answer questions if I am not here. So a little heads up that this is coming.
And we'll bring more of the rollout to the board in the April meeting, but with Sarah going on leave, we just wanted to give her an opportunity to share it directly, since this has been a lot of the work that she's put into over the year, and see if board members had any initial questions. If we want to pull back up the ED report, and go on to the next slide. Just a few little highlights and shout outs I want to give in the telehealth and digital equity space is there's going to be a conference in April, May, and Wendy's going to go presenting on the work of our telehealth work, and it is at the Northwest Regional Telehealth Resource Center Conference in Seattle, April 29th to May 1st. So I want to give a shout out to, and Wendy, I'll give you a chance after I go through these to share any comments you want, but just give her a shout out for all the work she's been doing around telehealth and getting the word out there across the state. Both Wendy and I will also be joining Sue Kane from the NCW Tech Alliance to speak about digital equity on NCW Life on March 5th. Wendy is also going to be doing a live podcast with Carrie Horning to talk about and prefacing this a little bit, she's going to share more details later on in the agenda about the Program Builders Grant that we just got awarded from Thriving Together. And then the other thing I just want to highlight out, our partner Kathy Latendre, also who does a blog post weekly, highlight the work in our blog post out to all of her partners and colleagues about the work that we've really been doing in our region around this. So partly I just want to shout out the work that's going on, that's been coming up, and also just this emphasis around how our work is starting to get picked up and recognized more broadly across the state, which is a good way to help really expand our mission and vision and support others in doing that work. And Wendy, I wanted to see if there was anything specific you wanted to comment on this slide.
The only thing I would say is the NRTRC stemmed from the telehealth conference. The NRTRC is the Northwest Regional Telehealth Resource Center. They're out of Utah, and they're one of, I think, 5 resource centers across the nation. And it's Utah, Wyoming, Montana, Idaho, Oregon, Washington, and Alaska, I believe. So it is the Northwest region. And they attended and presented at our telehealth conference in September. I was then asked to speak at the Washington State Telehealth Collaborative, which was in December. And after that, the NRTRC asked us to submit a abstract to present at their conference, which is in Seattle. So just the ripple effect of being able to present the to do the telehealth conference, which we did locally, and the statewide and now national effects that it's having, and the word getting out. So a lot of great work is happening, and people are starting to ask what we're doing and how we're doing it. So it's pretty exciting work.
And as you go on to the next slide, Caroline, I feel like that theme continues on as we're looking at our behavioral health and recovery work. And so I'm actually going to ask Joey to speak to a few of these items. I'm sorry, this is the ED report, and I've managed to delegate a lot of my report to staff, but I just was excited to have him provide some of these short updates out to the board. So Joey, I'm going to ask you to share a little bit about some of the key things on this slide here and what you're excited about this work.
Good afternoon, everybody. First off, before I get started, I'm a brand new grandpa to a baby girl that just melted my heart, and so I'm really giddy about that and excited to spend a lot of time with her. And it was an amazing experience so far. For the first update, the CLEARS project with University of Washington. This is a project that UW reached out to us about bringing together law enforcement, folks with lived experience, and also service providers to work on building relationships to understand the crisis response in community and identify a pilot and a new solution together. We had our first individual meetings. The first one was with folks with lived experience. This is a regional project, so we met in Grant County and collected some pretty awesome stuff around gaps in the community. And then we met in Chelan and Douglas. And then the law enforcement group met, and then the service provider group met, and here the next 2 days we're going to be meeting with all 3 groups and see what we come up with. It's hopefully some really good stuff comes out of that. The next project is the documentary on the recovery program. So as most of you seen, video that I did with my wife for Women's Resource Center last year. Because of that, the gentleman that did that documentary or that video works closely with a group called North 40 Productions, and they really want to do a documentary about this recovery movement in rural North Central Washington, really how it started, what it took to get where we are, the importance of utilizing folks with lived experience, with boots on the ground, doing community-based care coordination work, to really highlight what we've done here in North Central and how it's working to support folks who are struggling, and also to tear down the stigma and the importance of empowering folks with lived experience. And there's a lot of unknown around this project so far. We just have been meeting not too long right now, and they are really passionate, the group is, about this work. and have done some pretty awesome documentaries that I got to watch, and they really seem to key in on like emotion and the importance of that when you're trying to work with something like this recovery movement and how it got started. Like some of the ideas is like being able to share this in film festivals, maybe some digital platforms like Netflix and Amazon Prime, and also screenings that could be like in colleges and schools, and even smaller down to like local nonprofits, to really like advocate for what we've been doing here and how successful that is. The next project is the CPTS Summer Institute, which is going to be hosted in the North Central region. It's going to be at the, let me move down here, Wenatchee Convention Center. The purpose of this event is to bring together people from all over the state to strengthen relationships among agencies, families, advocates, and individuals in preparation for the productive and successful reentry work that's going on. Reentry is a process best sustained through collaborative partnerships, meaningful contacts, and dedicated individuals. The theme that we chose for this year is thriving through connection and community. And I'm excited I get to be a part of planning committee for that. And that's going to be July 30th and 31st. I think there was a flyer was shared in the board packet. Let's see, the next one is the North Sound Partner Convening. Really excited. I got invited to be a expert panelist for the North Sounds Partner Convening. It was held at the Tulalip Casino, and there was a few hundred people there. And I got to share a little bit about my story and the work that we're doing around the Recovery Coach Network in the jails, and some of the successes and challenges, and just really highlighting that work. They're really looking to do a very similar model in the North Sound region. And so it was just an honor to go up and meet some amazing people, and also got to be a part of a reentry work group with local partners that are really doing work around reentry, and just bounce ideas off each other, and really go into a little bit more detail of what we're doing here in the North Central region. Next thing, Narcan vending RFR submission. So I submitted an RFR for the substance abuse block grant dollars that are coming to our region this year and for the next 3 years. And specifically to support the Narcan vending machine project, to fund basically the bulk Narcan to supply those machines over the next 3 years. That project's grown. We now have 5 vending machines, and going to be a number 6 real soon. The 5th one is up at the Health and Human Service office on the Colville Reservation, and the 6th one is going to be in Ephrata, somewhere, hopefully at the emergency department, but there's going to be some construction going on there, and so we're looking at a alternative temporary location until that construction gets done. And the last one is the Advance is taking on the jail transitions program. That contract has already been signed, and moving forward with really the oversight of and admin support of this work. That project, it was really important to me because I was incarcerated on and off for a long time, and know what it was like to be in that situation without resources and hope and support from anybody. And so we're handing that off to a really good organization that's already really leading that work with the Recovery Navigator program and doing a really good job at administratively leading that work. And there's also not listed on here 2 amazing campaigns. One of them is the anti-stigma campaign. We're partnering with WISHA and the Grand Columbia Hospital Alliance to do a campaign around stigma and overdose, and that's going to be kicking off here very soon. And then the other campaign is around youth prevention, and that's going to be with Grant County Health District and some amazing staff that they have, working real closely with the youth prevention coalitions and really leading that in the schools and supporting a population that is a difficult population to support, and that's our youth who are struggling with addiction and mental health right now.
And Joey, is it with the partnership with WISHA, are they putting in an additional Narcan vending machine? Can you share a little on that?
Yeah, that's the one that's going to be in Ephrata. They're really excited about this project that we've been able to start and really see ripple effects going across the nation. But they reached out and wanted to fund the purchase of a vending machine and also some bulk Narcan to support that machine for 2 years. And so we're in the stages of the machine is being ordered and looking, like I said, looking for an alternative location until the ED construction is done at the Ephrata Hospital. That was a lot to take in. Does anybody have any questions? Besides how amazing it is to be a grandpa.
Thanks, Joey. That was wonderful.
Yeah, I think a lot of what you see and hear from the team today is that good progression of how we really have had some initial projects that we are finding the right organizations to take a lead on, and then how we continue to move in that advocacy and work with we're spreading the word, the growth of our programs, supporting on how we continue to build collaboration across partners. So a shout out to the team, and that's why I wanted them to speak on behalf of their own work on what they do. I did tell Joey, if you look a little bit closely at his beard, you may see a few more gray hairs appearing after having a grandchild. He may deny it, but I'm sure they're still there.
They are.
Any questions on any of the updates board members heard? Well, if you do have any questions, feel free to ask. As we get in throughout the year, we'll also try to provide a little bit more details under each of these programs, just to keep board members informed on some of the work that's occurring and some of the outcomes that you're seeing from this. But again, thank you guys for that. I'll turn it back over to Linda.
All right. Let's see, I'm checking our time. Wow, look at us. We're running right on time. Wendy, you've got some grants updates for us.
Yeah, you guys may recall, if you've been on the board for about a year, we talked about some of the career pathways in behavioral health that we had been working on. We approached we meaning Dr. Rickard and I had partnered together and approached both community colleges to see if they would offer the behavioral health support specialist or bachelor's degree in public health, because we knew that the 2023 legislation would come up, which was Senate Bill 5884. And this bill would require, which was eventually passed, required Department of Health to develop rules for the certification for a behavioral health support specialist. It defines the BHSS as a paraprofessional and requires Healthcare Authority and the Office of Insurance Commission to take actions that promote or require insurance coverage for the services. So it's a reimbursable now position. So we were trying to get our local community colleges to offer this bachelor's degree. We hosted a meeting over at Big Bend with several community partners, about just under 50, I believe, of those from education, first responders, clinical partners, and some community-based organizations. The bill passed in last year. And so we started working with Big Bend and Wenatchee Valley to start planning that. And they did submit their intent to apply to be able to offer this bachelor degree. But we also knew it was a heavy lift financially to be able to do this. So as an organization, we decided to apply with consent of the 2 community colleges for the Program Builders Grant through Career Connect Washington, which would allow them to, the funds would allow them to hire additional capacity to be able to build this program out within their community colleges. So we just found out a couple weeks ago that we were awarded the grant, which is just under $250,000. So we're pretty excited. I think it's like $600 under $250,000. So we're really excited. Very little of the money will come to Thriving Together. It really was a grant for our partners and how we're building the strategic partnerships with our community colleges. They did submit their statement of need to the Office of the Board of Higher Education, I believe it is. So we're really excited about that potential because they are moving forward. We will be a part of their advisory council as they're building out that and helping them form the advisory council, bringing the partners to the table and helping them connect with their clinical partners because there is a internship or clinical hours that go along with this. So they're going to expect their first cohort to start in February 2025. So this is really exciting work at building the career pathways. You may recall we submitted to OSPI about the certified for counselor degree or certification as an industry recognized credential. We're hoping that we'll hear something by the mid-February, so in about 10 days. And then that really is our career pathway that we're building from high school through the university system. And we feel like if we can grow our own behavioral health staff locally, then we'll be able to improve the staffing capacity locally. So people who are trained locally usually stay local. So I'm really excited about that work and what it can bring. Secondly, I want to just mention that the USDA has a distant learning and telemedicine grant, or DLT, and that is opening up end of February, beginning of March. You can apply. It's up to $1 million. There's a 15% match with that. This goes right hand in hand with all the telehealth work we're doing and the investments that were approved by the board a couple of years ago and that we're still working on. So that 15% match just is already what we're already spending. So we're not wouldn't be asking for additional funds if we were to get it. It's just really in line. The thing about the DLT grant is it's 90% capital or renovations and that type of work, and only 10% TA. Does not cover any kind of staffing. You can't do any kind of overhead with it. It's truly the purchasing of that. And so working with our libraries and our schools who are really building out those digital access points to be able to purchase the equipment that they potentially need to provide a private space and the computers and that technology needed for this work. So when that applies, we'll be working with Ingenuum, our telehealth consultants, who will help us not only identify, which they've identified at least 400,000, but they're still continuing the conversation because they believe that's truly up to about $900,000 worth of purchases that we could make. So we'll be pulling that stuff together and applying for that whenever that does open. And that's all I have. Thank you.
And Wendy, I'll just throw in there.
Oh, shoot.
250,000. We want to keep the board up to speed
Froze
on
a
that
bit
because
there, John. You cut out. We didn't hear your first start.
Oh, okay. Can you hear me now?
Yep.
So with the telehealth grant, especially since that amount is going to be over 250,000, that would be a contract that would need to come to the board at some point in time when if we got to the grant, we got to that point. So we want to keep the board up to speed and comprised of the process and what's going on so that any questions or concerns come up, that those would be hit prior to applying for the grant so that when we get to that contracting piece, that there's no questions at that point in time. For the Career Pathways Builders grant, technically that's under $250,000. But as Wendy and I said, is only $600 under. So we wanted to make sure that the board was aware of it and everything that was going on. So that if you had any questions around it too, that we had that opportunity to answer that for you guys. Again, by technicality, that one does not need to come to the board for approval, but we also want to celebrate the success of achieving it and the great work Wendy and team did in putting that together, and make sure you guys get any questions answered. Hey,
We have a question? No? Okay. Waiver 2.0 and community-based care coordination updates.
so Caroline and I are going to split this presentation. I'm going to cover the statewide context that's been going on between the ACHs, MCOs, and the healthcare authority to get board members a little bit more understanding of how the details underneath the waiver. And then Caroline's really going to come behind and share a lot of the regional context associated with this work. This is slightly, we brought this forward because in a number, even in our finance committee and exec committee discussions and just general board discussions, people were just interested in understanding a little bit more about this waiver renewal work. We're going to be entering in a contract with the healthcare authority for the next 5 years. And so in a way, this is really presentation education 1 in a number that we'll hope to continue to bring to the board over the course of the year. What we really ask of all of you is whatever doesn't make sense that you have any questions on, feel free to ask. Anything that you're excited about, please feel free to express that. Anything you have concerns about, feel free to express it. If you ever get a point in time where we present to you and you're like, there is a number of terms, language, anything I have no clue about, and I just want to know more, we're happy to schedule time with you individually to really do a deep dive so that any board member feels like they fully understand this. We know those of you who are around in the early days of Waiver 1.0 probably are familiar with at least some of the waiver language. Those of you who are new to this work, you may need just a little bit more understanding and have a number of questions on what the heck a waiver is and where does the money come from. And we are happy to be here to share any of those details. So if you go to the next slide, and actually you can go to the next slide. Really, the best way to sum up what a waiver is it's the state's way, an agreement with the state and the federal government, so that the state healthcare authority or Medicaid payer of the state can look at how they deliver care differently for the residents in our state that receive Medicaid. So it's a way to try innovative approaches in how Medicaid programs are designed to see if we can really improve the health and well-being of our residents. We did that in an initial 5-year waiver from 2017, ended up being 6 years, so really went into 2022. I would say for those of you were here in that initial waiver, a lot of the focus was really around healthcare transformation and how are we improving the healthcare system. As you look at that bottom bullet, what you see is waiver renewals are a chance to learn from those previous waivers and look at opportunities to reflect on those learnings and try new approaches. So a lot of the ACH work was really focused on how we can do this in a community-driven way and how we're really addressing those health-related social needs or those social determinants of health of individuals in our state. And so the waiver renewal really took a lot of those lessons learned. And they're starting to look at really now, how do we apply that more in the Medicaid space? That was some of the original intent the first 5 years, but I think just by the nature of this work, it ended up being more healthcare centric, and the state is really working to learn from that. If you go on to the next slide. So when you look at the goals of this waiver renewal, you can see them up on the screen. Really, one thing that's not really emphasized in the ACH realm is also expansion of coverage. And so looking to ensure that people have coverage that they can receive the care that they can receive. a term you're really going to hear a lot, I'm not going to read these bullets word for word, though, is really health-related social needs. And that's really the way that the state is phrasing, how are we looking at those health needs that individuals need, whether it's transportation, housing, food security, those things that are sometimes outside the medical realm, that really impact one's health, and how are we really creating a system to support residents in receiving those. The other thing I would call out too is really in the ACH space, a lot of the waiver is really focused on community-based care coordination, and how are we developing the infrastructure and system to provide community-based care coordination in our regions so that individuals can better get connected to the services. And then some of those health-related social needs services can find mechanisms to pay for the work that they're doing. If you go to the next slide. Again, this is a whole list of things that got approved under the original waiver. And as I said, there's a number of things even around medical eligibility or continuous coverage that is out there that we're not directly focused or talking about in the accountable community health space or in these board meetings, but just encourage you to read through the slate of things that are out there. Again, our focus is really around community-based care coordination and health-related social needs. We will talk, if you look at that bottom bullet, more on the reentry work that's occurring, and that's really slated to start July of 2025 in the realm of community-based care coordination. And so you will see that as well filtering in those conversations. The rest of this, as we get more information, we'll keep you up to speed. It's still amazing and great work that's occurring. It's just not as directly involved with the work we are doing. If you go to the next slide. A few things when we look at community-based care coordination that we do know is Waiver 2 is really going to focus and fund and sustain the vision of really Waiver 1.0 and DOH Care Connect. So a number of our regions, or all of the regions across the state, engaged in COVID Care Connect through the Department of Health when COVID hit. That, one of the benefit, let me rephrase. When we're looking at trying to find those silver linings in the crisis, the one thing I would say actually that was a silver lining was the state being able to develop Care Connect and look at really how to build out a care coordination network across the state. I think Waiver 1.0 did it to some degree and had some pushes in it, but I actually would give a lot of credit to DOH in the way that they were able to push it through COVID and Care Connect to really get a lot of commonality across the state and a lot of partnership. A number of the ACHs, if not all the ACHs, are really working directly with either the partners that have the Care Connect contract or they have the contracts themselves to really look at how they're infusing this work into the next waiver work. Really, as I said before, the funding that really is going to come through us and through the work of the accountable communities of health is really community-based care coordination work. So in our region, we're estimating that will be $32 million over the course of 5 years. When we think about the Pathways Hub and when we started that work in the original waiver, in the end, I think we spent between $3 to $5 million before we ended up discontinuing the Pathways Hub work. When you think about that, that's potentially the amount we're looking at spending per year over the course of this waiver, if not more. And so it just gives you a sense of how this work is really going to be bolstered over the course of the next few years. And what we did in the original waiver really was a small portion or attempt of that we will invest in or fund more in moving forward. Again, a lot of this work is going to be around health-related social needs services. So you're going to hear this term a lot as it relates to housing, nutrition support, transportation. The other thing that's going to come up, and you'll see on the future slides, in the submission to CMS, they consider case management as a health-related social need. And case management in CMS language really means community-based care coordination. It is just the way that they had to submit it to CMS to get approval. So when you look at this work, community-based care coordination or connecting with a care coordinator is considered one of the health-related social needs. And I already kind of gave the preview on the reentry population really being a big part of this work starting mid-2025. Go to the next slide. Any questions at this current juncture. All right, so there's really two primary ways that the state is submitting protocols to CMS for this work to be done. I'm going to focus really on the two columns to the left, HRSN infrastructure and HRSN services. I think the best way I can explain this is HRSN infrastructure is really funding to build up the core services of the hub and building capacity of our partners within the hub to do the work. So this is really capacity building. How are we investing in this care coordination infrastructure? How are we investing in the partners to do this work to get them to a level where they can engage? This would include grassroots partners who currently are out there providing community-based care coordination and would really want to move into a little bit more of an organized structure. Health-related social needs services is really the mechanism to pay for this long term. So once we get organizations up and running and they're starting to deliver services, this is a mechanism to create reimbursement for delivering of those services. So as we engage in case management or community-based care coordination, as you see on the lines, the middle of the chart, how are we really reimbursing for those services or paying for those services? The ultimate goal, I would say, is that as we get to the end of the waiver, we have the infrastructure in place and agreements to really transition these into long-term payments post the waiver. So as we build up that capacity and that infrastructure, as we move into the space of reimbursing for it, how do we demonstrate under this waiver that this is a more effective use of Medicaid dollars and Medicaid services, and that this is how we should pay and deliver services in the future, versus going back to the original structure where individuals either get their clinical care or they end up in the emergency department. I will just say on the reentry side, there's a lot of similarities, and the reentry planning and implementation is really about how are we building the capacity of organizations to do this work, including criminal justice capacity. So how are we getting the jails prepped to engage with partners in this work? And then in reentry services, how are we able to pay for those services? So those are the two primary funding mechanisms really to drive this work moving forward. If you go to the next slide. There's a lot on this slide, so I'm not going to read through it. I think I would just provide a lot of focus on that second bullet of really HRSN services, health-related social needs, are a set of menu of services made available to any Medicaid beneficiary who meets eligibility criteria. So the state, and I can share a protocol with any board members who are interested, submitted a services protocol to CMS that really outlines basic start of eligibility and what some of this would look like, and who would be Medicaid eligible. Since this is still a demonstration waiver, there's some flexibilities in how eligibility gets identified and set up. And that's really some of the discussions that we're engaging with in the state right now. If you go to the next slide. Again, this really just provides you a list of some of the things I've been talking about in regards to HRSN services. For those of you who have operated in the Medicaid space, there's similarities or comparables to what's been called in lieu of service. I don't want to give it a direct correlation, but the concept is the same, really around how are we providing a service that might not be a direct medical service, but is in lieu of it because it's more cost effective and it's better for the outcomes of the individual. Health-related social needs services is going to have to maintain that same kind of concept. It's not these services are open to all the time and that there's no justification for them, but how are we demonstrating that one will need these services and that is more cost effective and better for the individual to deliver these services and other potential health outcomes that they may engage in. I think the easiest example, sorry to go back to that, would be how do you do nutrition education and medically tailored meals versus ended up someone who ends up being diabetic and having a number of complications associated with diabetes and the costs associated with that as well. Next slide. Just to break down the two mechanisms, funding mechanisms out to give you a little bit more detail. So HRSN infrastructure funding is proposed to use to pay for 4 main buckets. So really, how are we supporting technology development? This could be platform purchases, training on a platform, API connections. So how are we supporting connections between platforms? How are we supporting that technology piece of this work? Business development of business and operational practices. How are we supporting organizations to have the operational infrastructure to be part of this work? Workforce development, how are we building the workforce and training the workforce into doing this work? This can include culturally competent workforce. And even in a space where we're really working and supporting engagement with individuals with lived experience, how are we creating a system in the workforce where those individuals who may be going back and supporting those who they were once in trauma with, how are we developing a system of support so that that community-based workforce has the support of their supervisor, the support of their peers, to be able to deal with what they might be engaging with day in and day out. And then really outreach, education, stakeholder convening, how are we really bringing the community into this discussion, and how are we funding building that infrastructure? Which, again, a lot of times people don't fund collaboration. Sometimes they don't fund community input. And so this is a way to make sure that this is a community-driven support. Next slide. And then again, this is just to really call out community-based care coordination or direct care coordination services is considered a health-related social needs service. And in the infrastructure protocol submitted to CMS, this is how the healthcare authority defined it. And I'll give you guys an opportunity to read it, but it really boils down to a community-based workforce and how are we developing and paying for a community-based workforce to connect with individuals to the services that they need. Next slide. This was the estimated funding breakdown for our region over the course of the 5 years. I think the emphasis I would say for those who were in Waiver 1.0 is that there was a general feeling under Disrupt that there was a lot of flexibility in the funds in the way that we earned them. I think that some of that flexibility will exist in Waiver 2.0. What I will say is that I wouldn't anticipate that we'll have any discretion to spend funding outside of community-based care coordination efforts. So whatever is really specifically called within our contracts and our work, the funding will have to be specifically used for that. We were lucky enough to have some of our discretionary funds left over under Waiver 1.0 that we are currently utilizing for a number of initiatives, and that just won't be there in the future. That won't be there for this in the future, I should say. Next slide. This just gives you guys a timeline of everything that's going on. Really, I would call your attention to the bottom right, where it says summer 2024 is when they really are expecting HRSN services to start. And so what we even heard today is July of 2024 is that start date, which includes, again, care coordination efforts. And then July of 2025 is when a lot of reentry work is going to get launched. Next slide. Any questions on the state context? Anything that is just utterly confusing? Peter.
John, this is it's a great presentation. This is a, very, how should I say, broad-based approach to care coordination, right? How will we sort of measure outcomes or progress along the way? How do we know what's working and not working, given how broadly based these initiatives are?
I'm going to turn that over to Caroline because I know she's been working with we have a group of ACHs that have been really working together, including looking at outcomes. So Caroline, can you share a little bit of that or your perspective on that?
Yeah, I think there's going to be some kind of standard measures around client engagement, improvements for clients, that will be tracked across all ACHs so that it's envisioned that we can roll up statewide data that can say that these community care hubs across the region served X amount of individuals, addressed X amount of social determinants of health or health related social needs. And, hopefully also outcome measures of like, they are now better off. People are better off. So those measures are being developed. It's still a work in progress, but there's a lot of attention to make sure that we're doing it consistently across ACHs so that we can roll up that data statewide. But that's like, there's also measures around workforce development. So number of community-based workers trained, number of trainings, there's going to be process measures to this. There's towards the end of the board meeting, we're spending a little bit of time sharing some outcome measures related to our work. So I can kind of loop back in on this question, Peter.
Thanks, Caroline.
Other question, let me ask, if someone came to you today and asked you to explain this work to them as an ACH board member or Thriving Together board member, where would you stumble?
I'll just give them your phone number.
I like that answer.
I would say it's still in the early stages and we're still fine tuning the program.
Linda said the acronyms. I wholeheartedly agree with you on that, Linda. Carlene, you came off mute, so are you thinking?
No, I agree. I'm just trying to comprehend it all. And but I would give them your phone number too. It's hard to explain.
Linda Parlett, I see you're off mute as experiencing this waiver 1.0.
I guess I would say this is a continuation of the grand experiment that the federal government has had with the state of Washington. And I also would say that I'm just so proud of North Central ACH right from the beginning, deciding not to be a provider group, trying very hard not to duplicate what's already done in the region. And the fact that we started here in North Central Washington with Joey's lead, this whole recovery program that is now being copied elsewhere. I don't think we have to have all the answers, but just continue to do the best work we can, trying to see what works, what doesn't work, and being independent thinkers, which is what we've been. And you all get the credit because, having the staff that has stayed here, other than those who have moved, that continuity has really given us a lot of strength and historical knowledge. Okay, I'm done.
Perfect. Peter, I see you wrote a comment in chat and you have your hand up.
Well, John, you always ask the best questions, like how would you explain this? And that's sort of a terrifying question, but it's really good. It's important that we, the board, understand and that we can respond to that. And I just look at what Joey's done and the fact that, here's a very personal and accessible example of, a kind of care coordination through all this peer counseling. And I think what I would want to do is get information from Caroline on, a couple of things that we're doing specifically and get the stories behind it and how it works at the individual level, because the macro level is kind of overwhelming, I guess. That's how I would respond, but it's a really good question.
Perfect. And we can work on those and continue to bring them back to the board. And maybe this is a good segue for Caroline to get into some of the more localized context. Unless Caroline, you unmuted, so you had a comment too.
Nope. I was ready for the segue. And I have to say that working on the community-based care coordination work over the years, like I sometimes feel like I'm like a plumber who's talking to people who all they want to know are like about the pretty fixtures, but really what I'm working on are like the pipes behind the wall that nobody cares about. And when I say I really mean like the network of partners that we're engaging right now. So just think about that analogy a little bit right now. We are focused on connecting the pipes behind the wall so that eventually you can turn the faucet on for care coordination in various areas of our region. And there's a lot of things that aren't quite in place. And I'll kind of describe some of that right now. But let me go back to screen sharing. I'm going to share, you heard John describe some of the statewide context, and you know, as part of the waiver, all ACHs are going to be focused on building out community care hub functions and health-related social needs. Our goals and objectives are really the same. We're trying to organize a network of partners that can bridge the health and social sectors. For years now, since we discontinued the Pathways Hub, we have been working with core partners to think about how we improve this community-based care coordination infrastructure, right? Like the pipes behind the wall. And that's a much bigger picture than Waiver 2.0. The success of Waiver 2.0 hinges on having a solid infrastructure. So all of that legwork we've done over the years through work groups, we had a care coordination platform work group, we still have a resource directory work group, and then we recently convened, well, in September, our first meeting of an advisory committee around community-based care coordination. So the thing I want to underscore is that it's not just us staff trying to like think internally in our organization how to do this. It's really been a lot of dialogue and making sense of things with partners who do this work already. So they are the experts, they know what's working and they know what's not working. And the other kind of thing I would point out is that a lot of the partners we've been engaging in are the non-clinical partners. So like the social sector side of this infrastructure. So some of our core assumptions that I think are really important are listed out on this slide. So we already have partners doing amazing work, and we want to support that and not duplicate it or disrupt it. The term hub is really misunderstood. So like you'll hear references to the hub or community care hubs. It means a lot of different things to different people. So we've been working together on making sense of what do we mean when we say hub, and what does that even look like? We're in our region more interested in promoting a connected network than building like a centralized hub. And I'm going to show you some pictures that illustrate what I mean by that a little bit later. And we also have to recognize that in this community-based care coordination network, we have partners that play distinct roles and functions. And teasing those out is actually really helpful to build a good system. So before I move on to the next slide, there's a couple organizations I want to call out who are critical to the success of all of this. They're really, really core partners, and that's Action Health Partners and Advance. So you heard references to Advance earlier. They're really leaning into the Recovery Coach and Recovery Navigator program and work across our region that Joey started, and we kind of handed it off, and now we're hoping to grow it even further. Action Health Partners has been a health home lead for a long time. They were brave enough to like battle the Pathways Hub experiment. We learned a lot through that. But the point is that there's a lot of programs that are part of this puzzle. We have to figure out how to think about health home in this infrastructure, Care Connect, DOH Care Connect, recovery coaches, recovery navigators, even the program from Waiver 1.0 called Foundational Community Supports. In some ways, it's a type of health-related social needs, like they address employment and housing. And then we have to figure out how to weave the Waiver 2.0 into this. So we can't ignore that bigger picture. If we just build something for Waiver 2.0, then we're going to miss a lot of parts. Like honestly, many of the partners we're going to lean on for Waiver 2.0 are already involved in a lot of the programs I mentioned. And if we don't pay attention to that, we're going to wreak havoc. We're going to cause duplication and disruption. So if we are successful with our big picture work with our partner network, here's what we hope to build: a network of thriving community-based care coordination organizations that function as an integrated, cohesive, and nimble system. So if there's one thing that you could learn to repeat, it's this sentence. So when people ask you, what are you guys up to? This is what we're trying to build. And I know that it still sounds a little bit like wonky and vague, but some specifics, like I think we're really trying to think about how to build this network so that it's inclusive of all payers, not just Medicaid, so that it's inclusive of different target populations, whether you tested positive for COVID or whether you are in recovery or on Medicaid, it doesn't matter. Like if you are suffering or struggling, you probably need some care coordination. And then I mentioned earlier, we're trying to weave in all the different program models. So the thing that we've been trying to make sense of with our advisory committee and our network partners is kind of these different levels of this infrastructure, right? There's some distinctions that, and these words, these terms are not perfect, but they're kind of like, we try to make them general. So regional system stewards, like folks who are just looking at the whole big picture, that would be us as an ACH. We are squarely in this dark green layer. There's community-based care coordination program administrators. And what I mean by that, oftentimes these folks are referenced or referred to as third-party administrators, network lead entities, and this is really the layer that is called out as a hub. Like if you're a hub, you're operating in like this blue layer in the way we're envisioning it. So Advance and Action Health Partners are local partners that are in this layer. Then they contract data with a network of folks who provide community-based care coordination services on the ground. And those organizations we think of as being in this lime green layer. Sometimes you'll hear terms like care coordination organization or CCO or care coordination agency, CCA, but essentially these are the organizations that employ people who they're kind of like generalists. They're care navigators, care coordinators. They don't specialize in any one thing, but they help people apply for benefits. They refer them, they check that they were served, they got what they needed, they help them when they get stuck, right? Those are the community-based care coordinators. And then another really important layer is this yellow layer of social, human, and health service providers. So the health-related social needs that John called out earlier, they're probably going to be delivered by organizations that operate in this yellow layer. And our healthcare partners operate in this yellow layer often, you know, so like think of it as the specialists who provide discrete services or discrete supports, whether it's nutrition, food banks, transportation, you name it. And it's not that these like elements or these levels are really perfect, like it's not that clean cut in reality, but distinguishing between these roles and functions is helpful when we start to build and connect the system. Like it helps us know what do you do and what do you not do. And then it also helps people, you know, you might operate in more than one layers, right? You might provide specialty services and also have a workforce of care coordinators. You might oversee a program, like as a program administrator, and you might also have staff that provide the services. So this is just something that has started that shared language and framework has helped our partners talk about like who are we in this system, and then how should we connect. So let me move on to the next slide. This one is in your packet. I'm not going to spend a lot of time on this. I feel like I described some of it already, but it's just a one sentence description of these system roles. And again, I just want to clarify that even though other ACHs are trying to build a community care hub infrastructure, like we're all doing that as part of the waiver, for us, we're building that capacity externally. I would say that's the main difference. Like when we're talking about a hub community healthcare hub capacity, we're building it out in the partners that already do this work so that they can do it better, instead of building out that infrastructure internally at our ACH. Okay, let's go to pictures. So I've explained this to a few of you, and I feel like it can be helpful in figuring out, like, okay, what is it that we're trying to build here? When I say we're building the pipes behind the walls, or like we're building a system or an infrastructure, like what the heck does that actually mean? So if you imagine all these dots being organizations across our region that are providing services to our community, whether it's healthcare, transportation, nutrition, housing, you name it. They're there to serve people. Now, when we think about how we want to connect this network together, the structure matters. It actually does matter how you connect the partners across our region. And also, it matters how things are already connected, because you have to work with the way folks are already working together. So you could connect all these dots this way, which is just kind of like a distributed network. Everyone's connected, but there's no real like structure that makes sense. Here is an example of a centralized network structure. I would say that this right here is what people think of when they talk about a hub, the hub. You see a hub in the middle and the spokes. And a centralized infrastructure, basically you're just concentrating the planning, the oversight, and the control of processes in one entity. And it can be really helpful for consistency, efficiency, economies of scale. Like there's a reason you might want to develop hub and spoke kind of structures in a network. There's also networks that are more distributed, where you kind of see hubs and spokes, but there's more than one, and they're connected in certain ways. And I would say that this is probably more the reality of what's going on across our region, across programs. So when you think about Health Home, and you think about Care Connect and the recovery navigators and coaches, they're already all connected in certain ways. They're referring out to certain agencies. And we have to work with this structure. And this is one of the things we've been trying to think about with our advisory committee is it doesn't make sense to build a centralized infrastructure for the entire Waiver 2.0. Like we have to leverage some of the hubs that exist and build their capacity to deliver on the expectations of the waiver. So the bottom line is that if we match all those little levels that I shared with you, those colors that represent different roles and functions, like we're just trying to be intentional about the network we're designing. We're trying to understand where are those blue program administrators and who do they contract with? And that community-based workforce that does community-based care coordination, who do they refer to? Those are the yellow dots, right? Green dots would be the community-based care coordinators. Yellow dots are the folks they refer people to. Blue are the hubs. So we're trying to paint that picture together of what exists right now and how we might be able to like connect it better so that it's more efficient and more effective. And John mentioned a lot of capacity building funds earlier. And I would say that a lot of the work of the Waiver 2.0 will be building up this infrastructure, and we'll be spending a lot of time and resources making sure that the folks who are already acting as hubs are well resourced so that they can do it even better and so that they can administer the Waiver 2.0 expectations. And then we also want to make sure that the folks who do the work on the ground are also really well supported and providing excellent services to our residents. So that's our goal, but it takes some network design and thinking. And this is the pipe building. And then if it all works, then people can start to be referred and get the services they need. And ideally we hear less confusion. We hear fewer like, oh, you're just duplicating services. Like that's the goal in terms of like what we would want to hear if we're successful. And the last thing I'll say before I end the slideshow is that the folks who are advising us represent all of these different levels that I shared earlier here. So we have folks who have perspectives of this entire system so that we're not inadvertently building something that, you know, organizations like community action councils are like, that'll never work, or, oh, we already do that. Like, we're trying to get people to think about this together and design it together so that it works. Works better. The Pathways Hub model, I think, was very prescriptive in terms of how to design the model and how to operate it. And so we're trying to learn from things that didn't go so well then as we think about how to structure this together. I'm going to pause there and just see if there are any questions. That's the bigger picture, that if we're successful, then it really means that Waiver 2.0 will be much easier to deliver on. But this is not easy work. It's very slow. Lots of dialogue and sense making. I see a couple. Yes, geography does matter, Peter. And I think that's why we have to honor and acknowledge that there is a decentralized network across our region, because geography matters. And there, even within specific counties, you have natural communities of care that work together on behalf of residents that you need to tap into. Any questions, or have I completely lost you?
You got us started, Caroline. Thank you. That's a lot to take in.
Absolutely. The graphic was very helpful.
Good.
And
Yeah, need some different ways to relay the information, because it's complex work.
The thing I'll also say is we've had an opportunity to present to the CEOs of the FQHCs, the administrators at the public health entities as well. And so that, as you guys are out there engaging too, Manuel, you can tell us if you found that useful, or if Jesus and Sheila found that useful. But we're also happy, we've had versions of this we've gone out to present, and we're happy to continue to do that, so that as these questions also come up as board members, as Peter said, you can phone us and we can also come be that support. Was that useful, Manuel, you feel like?
Oh yeah, the presentation and the graphics that Carolyn put together were fantastic, particularly the one with how the dots were connected. I think really helped understand. As we talked about, you know, I think that the ultimate goal here is to try and get everybody to speak the same language, so to speak, so that, and using the same system to communicate referrals back and forth. And that's what's going to be I think the ultimate goal with all of this is, how do, you know, everybody wants to help, but how do we all speak the same language, and making sure we're using the same way and systems to connect everybody.
And that's where, like, some standards are going to be important, because when I say standards, I mean the way, you know, basic data that would be shared for referrals, or the way we collect certain information. Because if you have some standards across a network of partners, it's easier to share information even if you don't use the same system. Like, let's say, you know, your FQHC, Manuel, has their own EHR, and there might be ways to connect other systems to your EHR to make referrals. Like that's years down the road, but it is possible to integrate different IT systems. That's another thing that I think comes up a lot in care coordination, is this idea that we all have to use the same system, the same IT platform. Those conversations come up at the statewide level too, and that's not a reality. So we have to figure out how to enable different systems to exchange information as easily as possible. Well, reach out if you have any questions. I spent a lot of time thinking about this, and I still confuse myself sometimes, or I don't realize that I make no sense to other people. So never hesitate to tell us if you need more information, or if we need to relay the information in different ways that allow people to get excited and want to work on this with us.
Peter, I saw you unmuting. Did you have a question or comment? All right.
I think we're done. We're pretty close to time, right, Linda?
We're doing good. We're a little 3 minutes over. So do we want to, let's take a stretch break? And it's, by my computer, it's 3:34. Let's come back at 3:40.
I think we are.
Think so.
I see Peter.
I see Peter.
Yes,
Are
we
we
can
ready?
probably get started, Linda. If
Okay.
a board member's here and they can turn on their camera or give a thumbs up to signify we know you're here, that would be good.
Okay. See, you practice your balloons. Confetti. I don't know if it'll work. Okay. But I digress. And Morgan, are you ready?
I'm going to share my screen.
Anti-stigma campaign and website preview.
Okay, so Joey touched a little bit on this earlier, and essentially we are working with some different partners to launch this anti-stigma campaign that will go live next week. And when we are working with our partners, we were trying to figure out where we wanted to host kind of a landing page so that people could come back and find all these great resources locally. And so we decided to host that on thrivingtogether.org. So this is a preview. It's not live just yet on our site. It'll be live later this week before the launch next week. And so we just kind of wanted to give a little bit of a preview and let you guys know that this will be hosted here on our website with lots of really great information. The goal of the campaign really is to provide people with resources so that they can help loved ones who might be experiencing substance use issues and to really kind of normalize those conversations. So again, we have a lot of great resources that we worked on with our partners and some good statistics, links to how to have, difficult conversations, information about Narcan, linking them back to our different locations where we have our vending machines, and then some extra resources here. We also wanted to share stories of recovery and just kind of highlight how talking about people who are able to, find recovery after active addiction can really empower and encourage those who are currently experiencing substance use problems to just have, more hope for the future. And then linking back to the series that we helped with Washington Recovery Coalition, Central Washington Recovery Coalition's Stories of Recovery on YouTube. And then we also will have a media toolkit. So we'll send out an email campaign when all of this is live next week. And this will be for any partners who want to help kind of spread this message, these couple different messages that are part of the campaign, and use, social media images on their own platforms, send out emails, that kind of thing. So there will be a personalized toolkit that they can access there. And then we just have a link to the partners that we've worked on for this project so that we can kind of showcase this group that's come together and put these materials, in a digestible kind of format for everyone to view. And that'll link back to each of their own websites. I'll kind of pause there, and I think Joey and Wendy are both here on the call if we have any questions. We'll also be doing some billboards up throughout the 4 different counties. So those will have images
that are part of this campaign. And then it'll also encourage people to go back to our website so that they can find more information. And then it'll have our logo on there as well. And I will be sending out a press release next week. And then I think I touched on the email campaign that will go out to all of our partners as well. Any questions on that before I jump to the next website preview?
Joey and Wendy, anything else on the campaign you'd want to make sure to highlight?
No, I think Morgan covered it well.
I think the only thing I would point out is as you look at the logos, you'll see that there are some hospitals outside of our region that are partners. And that's because this is the campaign is a HRSA campaign. And so we're able to access that because the Washington State Hospital Association has the Rural Community Opioid Response Grant. And they're working with the Grand Columbia Health Alliance, which includes all those hospitals. And because of the work that Joey's been doing with opioids, they've allowed us to tag along and then offer that entire campaign to our region, not just Grand County. So another example of a strategic partnership that we've been developing.
All right, I'm going to switch over to another part of our website that will be live also this week. We're just making some last final minute touches. And this is our new vital conditions page. So this is really a culmination of what Sarah has been working on to get lots of great data available to us on the different vital conditions using IP3. So this is the landing site that will be hosted under. So it'll be the vital conditions page that will be a drop-down menu item that will live under the Our Work section at the top of our website. So it gives a brief description of the vital conditions and how that's the framework that we've really adopted to start working upstream, and then touching on the vital conditions themselves, and then also how they intertwine with urgent services. And then from there, you'll be able to scroll down and take a look at all of our different reports for each vital condition. So when you click on each of these, you'll be taken to a new page that kind of breaks down a summary of that vital condition. We also have just some kind of easy to read bullet points here that are resources that, again, summarize that vital condition. And then moving down, I think it's still loading. Moving down the page, you'll actually see the IP3 data that Sarah's been working on in the back end of IP3 to kind of culminate for our region. So there's lots of great infographics here. Again, brief description of that vital condition. And then it's broken down into additional details, and you can see different indicators for specific to our region. So you can filter, I'm sorry, state and then national. That's right, Sarah? It's state and national. It's supposed to be there.
It's our region as it compares to national and state.
Thank you.
Correct. Yeah.
Okay, great. And then there's some local resources as well. So this is another thing that Sarah's been working on, is going through each vital condition and trying to pair stories from our partners that really highlight that category. So this, as we continue to make edits and include more items later down the road, that's something that we can just go into the back end of IP3 and update, and then it'll automatically be reflected here on the website, which will be really nice and cohesive. And yeah, am I missing anything, Sarah? You want to touch on?
No, not too much. So yeah, we're starting with just each of the vital conditions, but we also hope to eventually be able to kind of show how the vital conditions really work with each other. And so, you know, while we have a thriving natural world, report and a belonging civic muscle report. You know, we also might create like belonging in the outdoors type report and be able to highlight how some of the vital conditions are all connected. So the reports themselves are now active. We are still working on some of them, so don't judge them too harshly. Again, working on a tightened timeline because of me. So Morgan will make them beautiful over the next few days and weeks. So just be gentle.
And the website to access all this will be active at the end of this week, right, Morgan?
Yeah, so we're just working on finishing to embed. We have the belonging and civic muscle report. When you click on that, it's all embedded and ready to go. We are just working on getting the other vital conditions embedded, which will just be a really quick process. And then, as Sarah mentioned, what we wanted to do, instead of, we had a couple of different options when we were displaying on the website. So what we decided would be best to do would be to put up all of the vital condition reports. And for example, like Thriving Natural World, if we haven't sourced all of the data that we want quite yet, at least we'll have something on that page so people can navigate to, instead of, you know, as opposed to having a finished product, you know, later down the road and in the time being put, you know, coming soon. So we just wanted to put some information for everything and get that out there so that people could kind of sift through. And then again, later down the road, as we'll continue to improve the reports and add more. And yeah, it'll just be kind of an ongoing process. Any questions?
If you hear of a story or your own organization would like to be featured, let Morgan know.
And then we will just be adding one more section so that people can, down here, if they want to actually get a login to IP3 and to be able to see that information on that platform instead of just our website, they'll be able to get a specialized link. So that'll just be the other addition we're adding. And Peter, it looks like, has his hand raised.
Yeah, I was just thinking that, you know, this question of how do we as board members communicate what the organization's about, you know, at a level that we can embrace. It seems like this would be a really good tool over time to put in front of people about thriving together and say, you know, these are the vital conditions, these are the things we're measuring, you know, these are the things we're working on. Anyway, I really like the framework, and I think it would be useful to me as a board member as you build it out. I just wanted to say that. So
That's perfect to know, Peter. And like overall, and you'll see later on when we talk a little bit more about the outcomes, really the ultimate goal is to improve well-being and those measures under the vital conditions. And that's really what we're striving to do as an organization. So this really helps explain how we do it and some of the process steps we will measure as well, but this really explains our ultimate goal.
And hopefully helps us track some of our work and any improvements that we can see within our region.
Okay. John, advocacy proposal and work.
All right. Apparently, if you can bring back up the slides. I shared in the board packet a proposal for consulting services from Lodestar Partners, which is they work across the state in advocacy and in lobbying, mostly in state government, but they have a local individual, Blake Baldwin, who resides in Wenatchee, who also is part of their partnership and their consulting firm. And so I'll preface this reviewing a few things. We did get a formalized proposal from them. Ultimately, what I wanted to bring to the board is really to share where we're looking at going around policy and advocacy work and potentially partnering at the state level for that work. And I wanted to get board feedback around how do you feel about this direction? What things excite you? What things potentially concern you or raise a red flag for you? As we move forward into looking at either contracting with someone to support this work, or as we look forward into building out advocacy and belonging support in our region. And this really ties to, a lot of this work really ties to, I would say, that priority number 2, which is to really create learning, investment, and advocacy opportunities to strengthen belonging and civic muscle. So really, where is those advocacy opportunities we can lead into the strengthen belonging and civic muscle? And so the proposal really is outlining one concept and how to do that. So if you go to the next page, the next slide, and I've had a few conversations with Blake on what this could potentially look. And so there's really a few goals I would call out in mind here. It's really looking at how we develop a legislative strategy that's collaborative and is focused on our vision of thriving and the vital conditions of health and well-being. And so I would give Lodestar a good shout out is that they did within their proposal look at how they would really build policy and advocacy items under each of the 7 vital conditions as a template. That's not necessarily how it would go, but just as examples of how we could start thinking about it. And then really this process of really engaging stakeholders to ensure that policy issues that are part of Thriving Together is informed by community needs. And honestly, I've had a few conversations with Blake about this, and this would be the one emphasis of, as we're looking at moving into advocacy and policy work as Thriving Together as an ACH, we want to make sure that it's not just internally designed by us, but it really is addressing our network around the vital conditions, and it's really a need across the region. And so how are we also engaging community in a way to help inform our advocacy agenda? And I would say that's slightly different from other agencies, because a lot of times, and this is slightly nuanced with even what conversations I've had with Blake and his firm, is a lot of times they're developing priorities of the agency, potentially priority of some of the key partners of the agency, but it's more internally developed with our goal of really having this community driven. It's not necessarily what my priorities are, but it's really what are the priorities of the partners. If you go to the next slide, I just cut and paste a few of the timelines of what this would look like to give board members a sense of the kind of work that would occur over the year. So what they actually propose is basically a year-long contract that would, after session ends at the end of this year, would lead into a process that would get us through next legislative session. I've talked to Blake a little bit about not just the nuances of state advocacy and lobbying, but also how do we infuse working with local elected officials as well for those partners in our region who don't even have advocacy or voice power to really even have those conversations at a local level. And how do we build this into some of this work as well? But really what I would say is some of the key things that they've recommended is really how do we get the board and staff together to really start thinking of how do we put some guidelines or frameworks around objectives for legislative priorities? How do we go out and engage stakeholders into this work? And then there was a recommendation to form a legislative steering committee that helps guide this work over the course of the next few years. And I've had a chance to talk with Blake about that. I've also had a few conversations with Monty Roulier, who is supporting Veronica in the Stewardship Council, and how this aligns with the work that we were doing with the Vital Conditions Network, shared measurement, and everything else under that. Really, this would be getting us a base foundation in how Thriving Together would do this work across the region. If you go to the next slide. When we move into the second half of the year, this is where once we get that really foundation established, we would look at going out and developing legislative priorities in a collaborative fashion. This is actually an area I'll call out to you guys, I think could be more strengthened in their proposal around how we're doing this in a community-driven fashion. It just wasn't as called out as much in the proposal for that. But that's, again, one of the focuses I'd want to put into play is how are we working as a network to identify priorities that then Thriving Together supports and advocates up to the state. The one thing I would be careful is I'm not suggesting, or I'd want to be clear, I'm not suggesting that we take on every organization's legislative priorities or advocacy priorities. If we did that, we would not be very useful. And that's why I think having a steering committee to think about how we really look at it as a network is important, so that we're really identifying how we do this as a region. Next slide. And then one of the questions I've had some conversations with Blake, and this is also a question I would have for board members as well, and this came up when Linda and I were speaking a little bit over the proposal, is we really are focused on moving in a space of advocacy. There is times or emphasis when I've talked to Lodestar and Blake Baldwin as a connector, as there might be times where we actually want to move into a lobbying space as well, to lobby on specific bills and ask legislators to support certain bills or move amendments or work. That's where I'd be curious a little bit on board feedback. That's not really the original intent of what we're looking at moving into, but it is a potential. And I would say there are times where that might actually be useful. I've had a chance, I saw Kristen on, but I had a chance to talk to Sarah Krowski a little bit about nonprofit lobbying and what that would look like. And we as a nonprofit are able to have some level of lobbying as long as we stay within the rules and the regulations. We currently work as a coalition of ACHs with a shared lobbyist that focuses on some of our statewide efforts of accountable communities of health. And Sarah's really assured me that if we move into the space to a degree that they have a system in place to make sure we track it appropriately if we want to move into a space of lobbying, as long as we're adhering to all the rules associated with the nonprofit. But ultimately, really over session, we would look at as identifying some priorities to at least focus on advocacy on, if not lobbying. They would help us coordinate an advocacy day or a legislative day out in Olympia, and they would support really helping monitor and track the bills that come through and giving us a report legislative session. I think in regards to the consulting piece, having someone up there on Capitol Hill helping us track some of that stuff is very, very helpful. And then having a legislative committee available to provide some reactions would be helpful as well. So the one thing I would say a little bit about the proposal that Lodestar put forward is it's just helping put some structure or thought on how we would form this as an organization. Go to the next slide. I'm going to run through this really quickly, and you can ask questions. So I'm using Lodestar and the proposal as an example to engage this discussion. I want to say that if the board said we wanted to go out for an RFP, or if we didn't actually want to do a consultant, but we wanted to look at how we built this work internally, I'm not trying to push or at this current juncture say this is what I'm advocating for, is to go with the consulting firm to do this work. Why we engaged Lodestar and why you're seeing it in this proposal format is really that localized connection. And Blake, I've had a chance to meet with him and talk to him a little bit. He's worked with a few local partners, including Rural People's Voices and Chelan Port Authority. So that localized context, someone in our region who understands some of the issues of our region, who cares about our region, is one of the primary drivers on why we connected with them. And that connection was made through other partnerships. So originally some of this conversation came up in some of our digital equity work as a whole. I shared some of this with the executive committee a little while back as well. And actually having a broader experience outside of healthcare, some have seen as a benefit, some have seen as a potential risk, but really as we move into those vital conditions, having someone who's worked in something more than just healthcare might be useful as a whole. I just wanted to get preface on where we got to this proposal today. But if you go to the next slide. I'm running through this really quickly, but really two of the main key questions I really want to pose to the board members here is, what do you think about moving into this advocacy realm and how it aligns with Thriving Together's mission and vision? I would also throw in there, like, what do you guys feel about hiring a firm to support advocacy and lobbying at a state level? What excites you about that, and what concerns may you have or hesitations about doing that? And you have the proposal in your packet. Just again, as a concept of how we could conceptualize what this looks like. But if I put those two questions out there, I think I'd be seeking feedback from board members on how they feel about this. So I'll open it up for comments, questions, concerns, excitements. Peter?
I work on another board that has we hire a consultant to do lobbying. Not sure where, advocacy ends and lobbying begins, but I think it does make sense as long as we, live within the rules and so forth. But I do think advocacy really should be an important part of what we do. So I don't have huge concerns as long as we go, thoughtfully and carefully. I guess one of the questions is, how much, do we do in concert with the other ACHs and how much do we do alone? I think, to the extent our agenda is, aligned with all the others, there's strength in numbers, but also our issues are local. I mean, we do need to advocate for our particular region. So I guess the question is, how much do we do with and how much do we do alone?
And I think there will always be statewide issues that we do across the ACHs. I think some of this waiver 2.0 work and tracking of that's where we've aligned and worked with our coalition lobbyists on making sure the message to legislators were appropriate, and we all agreed on that. And I agree, we never really want to get into a situation where we're in complete conflict with the coalition of ACHs and the work we're doing. But there's just going to be needs that are localized of our own region that just won't always boil up to the state level. I see, I'm gonna pick on Manuel, Lori, or Carlene. I see Manuel thinking, so I'll go to Carlene.
Yeah, I think it's a good plan to do that. I just, you know me, John, and my concerns always with that, just like Peter says, moving forward very strategically. But yeah, I like it.
Molly, also, I forgot you. I'm sorry. You're right after Carlene on my camera.
I just think now would be the right time to start this discussion and start this type of work and finding what works best for us. Because the waiver is going to go away in a few years, and then what do we do? Do we, look for a waiver 3.0? No, we're going to look for other work, and I think this is good work for North Central Washington. I'm for it. I'm for it.
I just wonder, I guess what I'm trying to figure out is, advocacy and lobbying are taking the assumption that there's a limited amount of resources out there, and you're trying to direct the resources to your role or trying to change, regulatory issues to favor you. I'm trying to figure out who are we advocating? I don't want to make it sound like we're confrontational, but who are we advocating against? I mean, a lot of the things that we're trying to achieve are already advocated for in a lot of other areas. So what is the point? What are we trying to advocate for that we feel we're not getting already, either just through other organizations that we work with, each of us individually, or just because it's kind of the direction. For example, the fact that we have the waiver is already a good step in what we're trying to achieve.
One of the things that I think we could advocate for is the voice of the rural. It's sort of always our niche that we've had at North Central. And many of the state boards that I sit on, I am the voice for rural America. So we do have to keep that voice ever present in there.
Yeah, I think the two like small examples, and I'm not promising these are perfect because I'm exploring, I'm new into the space as well. Manuel, would be when we were originally looking at the Department of Commerce grants for digital navigation and that work. Within those conversations and with the Department of Commerce, one of our issues we had is that they were, in the end, they were funding agencies all on the west side that had offices in Seattle. And you know, I'm giving props because we're doing a lot of work in partnership with Community Health Network of Washington. So I don't want to like say that that's a negative, but one of the emphases we had on is that we wanted them to geographically disperse those funds more so into organizations that reside into those communities. Because a lot of what we were hearing is that our community was covered because an agency in Seattle subcontract with a few partners in our community. And it's different when the individual driving that work is in community focused on our work than necessarily just contracting out with a number of subcontracting out with a number of agencies across the state. And then I think the only other example this has come up geographically is in some of the discussions we've had about detox and looking at network adequacy. And for detox, network adequacy is as long as you have facilities within the state of Washington, which technically means you don't have to have a detox facility in our region to have network adequacy in our region. And so how do we advocate, again, for some of those rural changes to make sure that, like when we're looking at adequacy standards, that there's some in place that supports rural geographies. I'm not saying those are perfect, but those are a few examples that have boiled up just as a regional entity. And I'd also say, to Manuel's point, I think like one of the questions, that is a question we should continue if we move forward with this throughout the next year, is if we go through this and we get to the end of the year and we find out that we didn't need it or it wasn't as effective, that would be a good question to come back to and say, maybe we're done with this work, done with this contract, and we found ways to build it in other mechanisms. Other questions, comments?
Did you find, John, do the other ACHs, have they individually contracted with lobbyists or these types of organizations themselves? Was there maybe a discussion of just having one type of association working on behalf of all of the ACHs?
So Better Health Together currently does have their own individual contracted consultant who acts as their lobbyist. We as a coalition at ACHs do have a contracted lobbyist. So we do work on a coalition level to identify issues and needs as well. And so Better Health Together is really the only one who has one that's specifically localized and also works in conjunction with the state lobbyist. I've asked Allison, their executive director, if we can find time to chat so that she can explain to me a little bit more of the details of like how she balances those two out and where she finds benefit with her localized one versus the state one. And I can bring some of that back to you all to give more additional details on even the conversation I have with her, so you get a sense of how they've found benefit out of it. Or not.
Okay, this isn't an action item, so
It is or
next
is not? I'm sorry.
is not.
Okay.
Is not an action item.
No, and that would be, since I guess I would, if it's going to be a contract piece, I would see and work with the finance committee to see if we need to bring that contract for approval. It's under the amount. nor are we actually in a finalized contract for that. But if I got a sense from the board that we wanted to hold off or that there were concerns, and Manuel, maybe you and I can chat offline a little bit more about it to get a little bit more of your thoughts around it, then I wouldn't proceed forward with it either. Like, this is one area I want to make sure that board members feel comfortable moving into, that if questions come up of, you know, Thriving Together is working with X agency, why is that you guys feel confident that you can answer those questions. So there's no action items at this point, and I think I'll just continue to keep the board up to speed to any conversations.
Yeah, and I don't want, I mean, don't take my comments as negative. I mean, it's $65,000, which in the scheme of things is relatively small for our overall budget. But I guess I just, you know, as I'm reading through the proposal, you know, what do we get for $65,000 that we all of a sudden would say, oh, we can't live without? So.
And my thoughts, and John and I kind of talked about this, would be just maybe comparing a little bit. I know we went away from a healthcare lobbyist in this because I think it's been a while since I read the proposal, a couple weeks. A lot of energy things, and I know that the one is local, but it would, you know, behoove us to, for $65,000, get some other options or another option. Just a thought. If this is the direction we want to go.
Yep. So I think more to follow up on that, and I can keep the board comprised via email as well on any conversations or discussions. So no action at this point, and actually no full decisions at this point either.
Okay, we're now down to our last item. We're doing pretty good. Review of priorities and outcomes.
So I'm going to kick us off, and then I'm going to turn it over to staff as we get into each of the priorities. But ultimately, we wanted to bring back, in December, we shared our 5-year vision document with the board. We went through that and was able to talk about some of the key priorities and outcomes we're trying to achieve. One of the things that we committed to bringing back to the board was we're starting to develop outcome metrics and ways to measure these priorities and how we would achieve them. And so today we wanted to really just start previewing some of that with you all, see what kind of questions you guys have around it. And then in the future, again, pull back and bring it back to the full board. To be honest, you know, and I'll take the blame. I was hoping to be a little further along on this, but due to just things occurring over the holidays and that, we got a few weeks behind. And so you're more in a preview mode today than a full list of outcomes. So if you go to the next slide. Again, what I would always want to emphasize as we're looking at outcomes is centering on our mission. So to advance the health and well-being of North Central Washington by unifying partners, supporting collaboration, and enabling systems change. So again, with our ultimate goal, we're looking at how we're bringing partners together, how we're supporting to collaborate, and how we're working to change the system. And so how are we improving the health of residents by doing that? And you'll see that as we look at some of our priorities and outcomes, how we're trying to figure out how to track and manage that. If you go to the next slide, I shared this at the last board meeting, just general timeline. Like I said, we're going to provide some examples today. We had originally thought we'd have more of a finalized document, and we do not. So I just wanted to call out that I had committed to that in December. So I'm sorry, I'm bringing you more draft priorities and examples. If you go to the next slide. I think the one thing we want to emphasize is when we look overall measurement goal, and we look at how we're measuring thriving, well-being, and success through the vital conditions, you know, we will continue, and our partner network will continue to measure well-being and the vital conditions to determine if overall the health and well-being of our residents are improving or not, and what changes need to make to improve. So I say that because as we look at some of the measures, we're going to look under our priorities. If we achieve success in all those measures, but we're not seeing well-being improving, or we're not seeing those vital conditions improving, that's where we'd want to always come back to the board and say, look, we tried to make these changes to the system and we were successful, but it didn't improve the well-being of our residents. So was it the right change that we needed to make, or is there something else we need to do different? And that is a way of just kind of saying that we're ultimately trying to commit to not just the success of our individual priorities and outcomes or what we have control over, but how are we looking at how we might do things differently in the future to continue to move that metric of well-being and getting people to a place of thriving. A lot of that, and I give Sarah credit because the well-being survey will be starting to collect some of that primary data, and the rollout of the Vital Conditions Network data and information is going to help us kind of talk and answer those questions. If you go to the next slide, this is where we just wanted to start previewing a little bit of the priorities and where we are thinking and where are we going with some of our outcome objectives. And so I'm going to be asking Sarah just to talk through this slide a little bit as we're looking at our #1 priority and one of our outcomes underneath that and how we're developing plans in place to help start moving that along. So Sarah, I'm going to turn this over to you.
Great. So yeah, one of our tactics is obviously the well-being survey, to really have an understanding of where we are and what our baseline is, and to really work with partners to get the survey well spread amongst residents who are not usually surveyed or contacted. And so we really are using those kind of one-on-one tactics to help spread even the message of well-being and how important it is to our residents. So obviously measuring, we would love, the number of partners supporting the survey to increase over time, to see the number of survey respondents also increasing, and to see really a large portion of the survey is around demographics. And so making sure that that the survey is reaching those populations on the margins. And then I'm really excited to see how our partners utilize this data. We hear often that people are interested in this and they would like to use it. And so really, the end goal is to see all people and places in NCW feel that they are thriving, no exceptions. And so that's really where we're at. And obviously the IP3 dashboard on our website is really going to help explain some of that thriving as we go into community conversations, and also looking at a data inventory to help organize some of the data that is being collected throughout the region into a cohesive framework around the vital conditions. And so these are just a couple of our strategies and tactics for priority #1.
And Caroline, I'm gonna put you on the spot here really quickly because Caroline, you helped us, and you're gonna see this on the right side a little bit. Look at how we boiled these down in that format so that we can still really get to that bigger priority. So Caroline, can you, without like explaining each individual, can you explain kind of the concept of the image on the right for the board?
Yeah, it's just a simple outcome map where, starting from the tactic or the work that we actually do as an ACH, we kind of keep going through the rationale of like, okay, so we're gonna do this, so what will happen? Like, what's the immediate result of that? And then what's the next result of that? And so you have to kind of work down the chain until you finally get to results for residents. And I think that speaks a lot to the type of work we do as an ACH, right? We're not a direct service organization. So to get to the point where we can actually point to results for residents, we're going through so many chains because we're working at a systems level. And so in some ways, the things that we can directly measure are going to be these system level measures that are they might feel more like process measures, right? Like number of partners supporting a survey. You'll see some that Veronica and I also have. And, people might still ask, well, so what? Did it actually help residents on the ground? And that's certainly our theory of change. And that's why the data thriving and suffering is going to be so important. But I think it is really important to remember that as an ACH and a non-direct service provider, the types of things that we measure that are directly associated with the type of work we do is not going to feel like as satisfying as like individual level outcomes, if that makes sense. In the end, we want to get there. So you'll see on all of these diagrams, in the end, our vision is all people and places thriving. So it's always at the bottom of the chains, but.
And I think that speaks to a little bit as we're looking at process and error outcome measures. We're also trying to track what we have direct influence over, while we're also trying to move the needle on things that really we require partners to actively be engaged in wanting to do as well. Let's pause there as we look at the slide and think about this process and these outcomes. Does this seem to resonate with board members, or is there anything that seems confusing or missing the mark as we build these out? Peter.
So you said something earlier about, we're going to do all these things, but if the well-being's, based on the survey doesn't improve, then, we're going to have to rethink our approach. I mean, I just want to remind us that the world isn't static, and that, there are lots of other variables that come into play. Take, COVID, for example. We could be doing everything, right, and having a huge impact, and something like that lands on people that impacts their well-being that we didn't anticipate. So, we just, we have to understand that there are other things that will always be in play.
Yeah, thank you for bringing that up, Peter. So, while yes, this survey is pretty for baseline in terms of, what groups and areas are struggling and suffering, but then there's kind of a second phase to it in terms of, okay, well, why are they suffering and struggling? And some of that is included in this survey on kind of broad terms in terms of mental health, physical health, financial health, well-being, or community engagement. And so some of those will be kind of answered, so we can kind of track, we did really well in increasing physical health, but we're still struggling in mental health or in connection. So hopefully we'll be able to pull out a little bit more information, and then definitely through kind of our second phase of why, we'll get more of those answers and can keep track of that a little bit closer.
I guess I'm also saying that the process measures that Caroline pointed out, it's important to have those, because that's really, if you're not getting an outcome, is it because you didn't do the things you said you would do, or because the things you didn't have the outcome you thought? I mean, those are really two different questions and answers. And doing what you said you would do is important to measure, and that's what where those process things come into play, right?
And I'll just say, I feel like this was the same struggle we had in Waiver 1, when we had those regional health outcomes that we tracked under the waiver, and we were trying to figure out, to your point, Peter, with so many influences that can impact one's health, how do we tell if what we were doing under the waiver was achieving that, or if something else was just dragging them down or improving them that really we had zero influence over? So it's a great comment. Other comments? Or questions? If not, we can flip on to the next slide. And
Yes,
thank you, Sarah.
I do have a comment or question. So I guess what was, I mean, I don't know if we've tried before, but what do we anticipate in the process and interim outcome measures, number of partners supporting the survey? I know Sarah had mentioned we want more people to respond. Do you anticipate pushback from partners in supporting the survey and getting it in front of patients or getting in front of community members to take?
Not necessarily pushback, but I think that there are different organizational priorities that sometimes can you know, hinder the ability. And so, you know, as long as sometimes it just takes time and those like one-on-one conversations to really figure out how an organization can participate. So I think that's just kind of where we're at right now, is since this is the first time, we're not really sure of what hurdles we're up against. So far there has been, you know, everyone I've talked to has found a way to get the survey, you know, integrated into their organization.
The other thing I would throw in that's not listed here, but it would be, I think you could put number of partners involved, types of partners involved, geographic location too. Like, and some of the onerous and accountability would be on us too, to make sure that we are actually getting out there and engaging the different partners. And that if like we were to come back and share it in Okanagan County, we didn't have anyone in Okanagan County, that's also an accountability towards us to making sure that we're not doing that, or that we should be doing that. Next slide. So again, Sarah, thank you for kind of demoing this for the board today. So you get kind of a sense of kind of questions and comments we're having as we go through these 3 slides. So actually, Veronica, I'm going to turn this over to you to share more really focused under priority 2.
Yeah, thank you, John. Good afternoon, everybody. So yes, for priority number 2 under our larger 5-year plan, to provide learning, investment, advocacy opportunities to really strengthen that belonging and civic muscle, so that, you know, we have leaders across our region, I guess, will be more inspired and know how to engage and share the power of with marginalized communities to address disparities in our region. So the tactic or strategy that we've identified under this priority, one of them is community dialogues. And so basically the idea behind this is that more partners are trained on how to, you know, hold meaningful conversations and dialogues with their community members and partners, a place, you know, where community members feel safe to really share their stories and experiences and really call out their needs, so that, you know, partners really have, I guess, a better understanding of the community needs and just how to, I guess, better serve their community members. And so basically the, I guess, the ingredients behind community conversations are places where people are, you know, naturally gathering already and are generally comfortable, again, voicing their opinions and talking about their needs. And then typically they're facilitated by community members, leaders that are well-known and trusted within the communities, so that, again, members feel really comfortable to share their stories. And I guess, community dialogues, they're really structured around the spirit of dialogue. So some of the measures that we've identified are how many partners are trained in community dialogues? And I think this goes back to John's earlier comment within the other measure in the well-being survey, really identifying how many are trained across the region, and how many partners are already utilizing perhaps community dialogues as a mechanism to engage communities in this work, and increasing the engagement with grassroots organizations and residents. So there's I guess a few already organizations kind of doing this work, so identifying who those are and really working towards that goal of all people and places thriving, no exceptions. So kind of flew through mine pretty fast, but yeah, this is our, I guess, one of the tactics under priority number 2. So if there's any questions around community dialogues.
I think the only other thing I would throw to think about feedback we're looking from the board too is like, as we're looking at level of measurement, if you think like we're missing something, or if you're like, I like the process measures, but have you thought also, can we collect X? That might be a different layer of measurement. Those are also things we're looking at. This is really draft formats. So trying to figure out for the board, if someone were to come up to you and ask you, do you feel like Thriving Together is making an impact? What kind of things do you feel like in these measures you would want to see to help be able to answer that question?
I guess I'll take over and do the next one. Before I shift to it, I did want to also call out that in many ways, when I look at Veronica's outcome map here for community dialogues, there could be one that's very similar related to art of hosting. Like that's another tactic to get people to engage community in meaningful ways to solve challenges in their region. And in some ways, I would envision that these are the mechanisms that get us information that we can then feed to somebody like a lobbyist who can help go advocate for some of these barriers that keep coming up in community dialogue after community dialogue that are like structural kind of vital conditions barriers that require policy fixes. Like I could see it kind of those feedback loops starting to work together. So I just kind of wanted to mention that. The last example we had was for priority number 3, which is to support collaborative efforts that improve and connect systems of care across clinical and community settings. This includes the recovery work, all the great work that Wendy is doing, and also the community-based care coordination work. We just showed one example here, the tactic being increasing the capacity of local community-based care coordination program administrators and providers. So that I hope that language helps you remember what we shared earlier, like the blue and lime green partners in our region. So if we increase their capacity to do great work, in the end, we should see more people thriving. We should see fewer people suffering. And some of the process and interim outcome measures of our work are potentially measured by funds that are being invested in our partner network, right? That we're like waiver funds are coming through us, but it's really going to invest in the folks that are doing this great work across our network. The number of partners and community-based workers that are in our contracted network in the region, that could be a measure to see like, are we growing and strengthening this network? Like, do we actually know who's in it and how do we grow it? And then another thing that kind of ties to Sarah's earlier example around measuring well-being is that there are ways to incorporate simple well-being measures using Cantrell's ladders in assessments, intake assessments that you do with, like, think of any social determinants of health screening. You just add a couple questions related to the Cantrell's ladder, and all of a sudden you're asking residents how they're doing today, where they see themselves in 5 years, and then you can do it again, close the case, or you however you call it in your sector, and you can see whether you've made any improvements towards thriving. like they might not be a 10, but maybe they moved from a 3 to a 5 after working with a recovery coach for a year. So there are ways to also build this into case management work in our community-based care coordination network that could get additional data in it, like on top of the survey that we're sending out kind of more broadly. So I just kind of wanted to tie that in as well. Questions? Okay.
And I think maybe my overarching question I would have for board members is just a pulse. Do you feel like this is hitting the mark? Do you feel like you'd be looking close, but there's just something you could use additional information on, or off base?
I think it's good work in the right direction.
Yeah, I like the structure and the, just the way it's laid out with the tactics, process, measures, and so forth. It's concrete for me.
Were these slides in our packet?
They were, and to be honest, we'll send them out to share a little bit. This was a little bit of, we were putting them together this weekend.
All right.
So that's also why it wasn't complete transparency. That's why it wasn't in your earlier packet.
No, that's fine. I was surprised. I was wondering if I'd missed them going through the packet, but no.
No, but anything that's hasn't been in that's been shared, we'll make sure we get out to all. And again, as you know, these are areas we'd love your direction, because in some ways, we're also looking at all of you, or in a lot of ways, we're looking at all of you to be ambassadors. So if you feel like you look at this information and it still spurts questions, or if you feel like you can't turn around and represent when questions are asked to you, even if it's someone asked you if the Thriving Together was doing a great job on something and you looked at the data and said, no, actually we have to improve in X, Y, and Z. If you feel confident answering that, that's where we want to get you at, not so that you feel like you can be a representative as a board member. Perfect. Linda, I'll turn it over to you to close us out.
Okay. Well, thank you, everyone. Yes, I agree. That's a lot of material. I love, me personally, as Peter said, I'm a linear person, and the so that using some IHI healthcare improvement theory. So that organization speaks really well to me. Thank you, everybody. And it looks like we have about 18 minutes of a gift of time. So I will go ahead and adjourn.
Perfect. Thank you all.
Thank you.
Thank you.